This lecture is going to examine drugs that are used for erectile dysfunction as well as male infertility. Learning objectives are pretty straightforward. Basically describe the mechanism of action of the drugs commonly used for erectile dysfunction, as well as describe the mechanism by which testosterone replacement therapy assists in the context of hypogonadism. Understand first the causes of erectile dysfunction. They can be disease or physiologic versus drug-induced. In terms of disease or physiologic, we can look at disturbances in blood flow. We can talk about spinal lesions. We can talk about the obvious in terms of endocrine low levels of testosterone, as well as contributing or comorbid factors such as diabetes and psychologic factors as well. In terms of drug-induced or drug-related causes of erectile dysfunction, the antihypertensive drugs, particularly the calcium and the channel blockers and the beta blockers, are notorious for producing erectile dysfunction, and to some degree as well as the thiazides. Antidepressants, particularly SSRIs and TCAs, are also associated with erectile dysfunction in many of these patients. In terms of recreational drugs or illegal drugs, ethanol, particularly high doses of ethanol, marijuana, and cocaine are associated with reported erectile dysfunction in many of these patients. And so in terms of the treatment options, you've probably all heard of phosphodiesterase 5 inhibitors. Here's your Viagra, Cialis, Levitra, and so on. You can basically surmise that these drugs are very similar in their mechanism of action. The only thing is the duration of activity. Avanafil has the shortest duration of action, whereas tadalafil has the longest duration of action. And then Viagra and Levitra are somewhere kind of in the middle. So those are the phosphodiesterase 5 inhibitors. There also is another version where you're looking at, or another molecular target, where you're looking at prostaglandin analogs. And the main drug here is alprostadil, as well as the use of an alpha-1 antagonist, phentolamine. And of course, these two are by injection. So this is kind of a nice summary diagram looking at phosphodiesterase 5 inhibitors. And understand that we're really focusing on the corpus cavernosum specifically and that associated physiology. What these drugs do is they inhibit phosphodiesterase 5, which usually its job is to basically cleave cyclic GMP to produce just GMP. When cyclic GMP is preserved, you get more second messenger signaling cascades, which are listed here, and then the physiologic effects are summarized. And so you get protein phosphorylation, you get a reduction in cytosolic calcium. That's going to hyperpolarize the cell and promote smooth muscle relaxation. And then that smooth muscle relaxation will allow an accumulation of blood essentially within the corpus cavernosum to produce and maintain an erection. And so all these drugs, all these phosphodiesterase 5 inhibitors produce the same physiologic effect by inhibiting the same enzyme. And so this is, of course, a blockbuster drug. The people who made it and discovered it made millions upon millions of dollars. And of course, we've also been looking at using these drugs in other conditions. And so there are some criteria for using these drugs in pulmonary hypertension, to maintain patients with BPH, benign prostatic hyperplasia, even cystic fibrosis, and a few others. I didn't go into much detail in terms of some of the other uses of these drugs. I figured we'd cover them where appropriate or when appropriate. These drugs are orally administered, and they're taken kind of during or immediately after sexual stimulation to basically produce an erection within anywhere between 15 minutes to 45 minutes after the pill is taken. The side effects, many of these drugs potentiate the mechanism of action of nitrates in terms of smooth muscle relaxation. They too can produce headache and flushing. Nasal congestion is sometimes reported, as well as dizziness and back pain. Sildenafil, Viagra, is associated with changes in color vision, particularly blue and green. This is because there's a phosphodiesterase associated with the retina, not because the tablet itself is blue. And of course, you've heard the commercials in terms of erections lasting longer than 4 hours. Please consult a physician. And hypotension, of course, can occur. Now, in patients who cannot take or many of these phosphodiesterase inhibitors may not work in some of these patients, we do have a alternative, and that alternative is alprostadil, which is a prostaglandin E1 analog. This is injected into the corpus cavernosa, right into the penis, and it's placed as a mini suppository by the patient with a special applicator as kind of like a mini suppository. And so these drugs, as I said, were developed for patients who are non-responsive to drugs like Viagra, or drugs like Viagra will be contraindicated to these patients. Mechanism of action here, we're looking at stimulation of adenyl cyclase and an elevation in cyclic EMP levels, which of course will lower calcium levels inside the cell, and that will vasodilate penile arterioles. This drug works when it's professionally inserted, usually by medical personnel. However, when the patient goes home and tries to do this themselves, the success rate is about 50-50. And of course, even if the patient is successful, the associated side effects, including penile pain, priapism, and just in general uncomfortableness, typically warrant this drug as kind of a last resort. But again, it's really indicated for these patients who can't take the oral PDE inhibitors that were listed previously. Phentolamine, we had talked about a long time ago when we were talking about alpha and beta blockers. Phentolamine is a reversible non-selective alpha antagonist. However, when it's liquefied and injected into the penis, it becomes more specific for alpha-1. And again, this is for patients who are not responding to Viagra or sildenafil. The side effects include, obviously, it's an injection, so that hurts. It's not very comfortable, and it can produce prolonged erections as well as blood in the urine. Another drug, chlorpromazine, has been used similarly, and I would surmise that they're essentially equally efficacious. This is a nice summary chart looking at the mechanistic outcomes in terms of alprostadil, phentolamine, and your phosphodiesterase inhibitors. There are a few other drugs that are listed here. I didn't go into much more detail about them, but understand that there are a handful of drugs out there that are kind of coming through the pipeline that can and will be used for similar outcomes. In terms of male infertility, most often we're looking at surgical or procedural treatment options. Where you would actually see something like testosterone as a drug being given is typically for patients who have infertility due to primary or even secondary hypogonadism. And so this is androgen therapy. We wouldn't be using this necessarily for erectile dysfunction because most of those patients that have erectile dysfunction have normal levels of testosterone. There's no really need to add more testosterone to those patients. And in fact, it's discouraged and contraindicated. But in terms of testosterone replacement therapy, with the end target being treating male infertility, there's several preparations of testosterone. There's oils, subcutaneous injections, gels, implants, etc. And these can be weekly administered or every 5 to 10 weeks, depending on what the injection is and how quickly it's eliminated from the body. Clomiphene citrate has been used for off-label use in male infertility. It will indirectly increase testosterone by altering the negative feedback. And we'll talk about this in more detail when we talk about female infertility, which is its actual FDA-approved use. Okay? So these were the drugs for erectile dysfunction, and basically just reminding you that you can use testosterone for male infertility in the context of both primary or even secondary hypogonadism.